Welcome to our video on Sturge-Weber syndrome and von-hippel-lindau syndrome. Let's begin. Here's an overview of the topics we will cover. Let's start with Sturge-Weber syndrome. We'll review genetics, clinical presentation, diagnosis, and management of Sturge-Weber syndrome. Sturge-Weber syndrome is different from all other neurocutaneous syndromes in the sense that it is a congenital sporadic condition. In other words, it is not usually inherited from the parents. Instead, it is caused by a de novo mutation. It is also known as encephalotrigeminal angiomatosis because it is characterized by angiomas in the brain and on the areas of the skin with trigeminal nerve innervation. Sturge-Weber syndrome affects the neural crest cell derivatives. The exact genetic mechanism of this condition is the somatic mosaicism of an activating mutation in one copy of the GNAQ gene. The GNAQ gene codes for the alpha subunit of G protein, which normally activates the intracellular signaling cascade driven by phospholipase C. Let's move on to the clinical presentation of Sturge-Weber syndrome. These patients commonly have a port wine stain, which is also known as a nevus flammeus. A port wine stain is a capillary malformation in the distribution of the first and second branches of the trigeminal nerve. Please note that a port wine stain is not exclusively associated with Sturge-Weber syndrome, and it may be an isolated finding. Patients with Sturge-Weber syndrome may also have a leptomeningeal angioma ipsilateral to the nevus flammeus with tram tract calcifications of the gyri seen on imaging. Cerebral angiomas and calcifications can result in seizures and intellectual disability. Finally, patients may have an episcleral hemangioma, which causes an increase in intraocular pressure and early onset glaucoma. Here one can see a capillary malformation in the cranial nerve V1 and V2 distribution, which is a port wine stain. This is a brain CT scan of a patient with Sturge-Weber syndrome displaying calcifications. These calcifications are associated with leptomeningeal angiomas. Let's briefly review the diagnosis of Sturge-Weber syndrome. Diagnosis is based on a combination of the symptoms and clinical findings that we discussed on the previous slides, and genetic testing for the GNAQ mutations. However, genetic testing for GNAQ gene mutations is not routinely performed because, as we already mentioned, Sturge-Weber syndrome is due to somatic mosaicism. Therefore, one might not be able to detect a mutation in an obtained sample. Let's talk about the management of Sturge-Weber syndrome. Anti-epileptics are used to manage the seizures. Pulsed laser therapy, on the other hand, is used for the port wine stain. Otherwise, treatment is supportive. A 5-year-old girl is brought to the physician by her mother due to worsening left eye pain that started 4 weeks ago. She has past medical history of intellectual disability and tonic-clonic seizures treated with valproic acid. The physical exam reveals a large erythematous patch on the left side of her face involving the forehead, periorbital skin, and the cheek. An MRI of the brain reveals a left-sided vascular malformation in the pia mater with concomitant calcifications of the gyri. Ophthalmologic exam of the left eye reveals an intraocular pressure of 40. What is the most likely cause of the ophthalmologic finding in this patient? This patient presents with left eye pain. Her past medical history includes intellectual disability and tonic-clonic seizures. A large erythematous mass involving the forehead, periorbital skin, and cheek is consistent with a port wine stain or nevus flammeus. A vascular malformation in the pia mater with concomitant calcifications of the gyri suggests leptomeningeal angioma with tram tract calcifications. All these findings are consistent with the diagnosis of Sturge-Weber syndrome. This patient has an increased intraocular pressure in the left eye. Increased intraocular pressure and resultant glaucoma in patients with Sturge-Weber syndrome are due to an episcleral hemangioma compressing the eyeball. The last condition that we're going to discuss in this lecture is von-hippel-lindau syndrome. Here is a sequence that we'll follow as we describe this disease. Von-hippel-lindau syndrome is an autosomal dominant condition caused by a deletion of the VHL gene on chromosome 3p. The VHL gene normally codes for VHL protein that ubiquitinates and inactivates hypoxia-inducible factor 1a. Hypoxia-inducible factor 1a is a transcription factor that stimulates vascularization in hypoxic tissues. The VHL gene deletion in von-hippel-lindau syndrome disinhibits hypoxia-inducible factor 1a, leading to unregulated vascular proliferation and vascular tumors in multiple organ systems. Clinical manifestations of von-hippel-lindau syndrome can be remembered by the mnemonic HARP. These patients commonly have hemangioblastomas in the retinas, brainstem, cerebellum, or spinal cord. They also develop angiomatosis in other organs such as the liver and lungs. Angiomatosis is a benign blood vessel tumor. Von-hippel-lindau syndrome is also characterized by bilateral renal cell carcinoma. Finally, pheochromocytomas are prevalent in these patients. This is an MRI image of the spinal cord and brain showing hemangioblastomas in a patient with von-hippel-lindau syndrome. Hemangioblastomas appear as hyperdense circular structures on imaging. Here we have a gross morphological image of a renal cell carcinoma. Please note this golden yellow mass. The yellow color is due to glycogen and fat accumulation in the cells of renal cell carcinoma. Von-hippel-lindau syndrome is associated with bilateral renal cell carcinoma. This is a gross morphologic image of a pheochromocytoma. You can appreciate this mass arising from the adrenal medulla. Let's briefly review the diagnosis of von-hippel-lindau syndrome. Diagnosis is based on a combination of the symptoms and clinical findings that we discussed on the previous slide and genetic testing for VHL gene deletion. The management of von-hippel-lindau syndrome includes screening for associated tumors. We can perform abdominal ultrasound or CT to screen for renal cell carcinoma and pheochromocytoma. Fundoscopy is performed to check for retinal hemangioblastomas. If the tumor is detected, it should be surgically removed. Here we have a table summarizing all the neurocutaneous syndromes and their high-yield features. Pause the video and take a moment to consider this table. A 14-year-old boy is brought to the physician for a well child exam. He has no specific complaint. His past medical history includes unilateral nephrectomy due to renal cell carcinoma and unilateral adrenalectomy for pheochromocytoma. 2 years ago, he was found to have a mass next to the spinal cord after complaining of intractable back pain. Biopsy of the mass reveals blood vessels with hyperchromatic nuclei in the cells. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 110/80, and a heart rate of 92 and respiratory rate of 15. Which of the following is recommended for this patient on a regular basis? A. Fundoscopic exam. B. Complete blood count. C. TSH levels. Or D. Basic metabolic panel. This patient has a past medical history of renal cell carcinoma and pheochromocytoma. Presence of these tumors at such a young age already increases the suspicion for a genetic syndrome. Biopsy of the mass found next to the spinal cord revealed vessels with hyperchromatic nuclei in the cells. This is a classic description for hemangioblastoma. So this patient has a history of renal cell carcinoma, pheochromocytoma, and hemangioblastoma. Therefore, the most likely diagnosis is von-hippel-lindau syndrome. Let's recall that patients with von-hippel-lindau syndrome commonly develop retinal hemangioblastomas. This is why these patients need to undergo regular fundoscopy to check for retinal hemangioblastoma. Correct answer is option A. This is a slide reminding us of the management of von-hippel-lindau syndrome along with necessary screening tests. Let's discuss why other options are incorrect. Option B, complete blood count. Option C, TSH levels. And option D, basic metabolic panel, are all incorrect because none of these tests screen for complications of von-hippel-lindau syndrome and therefore are not indicated in these patients on a regular basis. And that concludes this section.